is just a huge honor for me today to be podcast interviewing Dr. Mohtashami. He is the founder of the Farran Institute, a postgraduate dental specialties intensive learning institution advancing dentistry through specialized intensive training designed to give dentists the cutting-edge skills needed to help restore the human spirit with every smile. In 1998, Sean opened Albright Dental in Las Vegas, Nevada. It thrived as a general dentist practice. He wanted more and more, and so he dove headfirst into dental implant dentistry. Upon seeing the remarkable change, both emotional as well as physical, that it had on his patients, he instantly fell in love with the process. He became the leading dental implant expert in the Las Vegas Valley. Looking to expand, he began traveling to Southern California as a dental implant expert, placing implants as an associate for other dentists. Dr. Sean is the artist and authority behind the 4M dental implant solution and an expert in cosmetic dentistry. He knows how to design a beautiful, personalized smile and says the road to excellence is endless. This is the motto which has inspired him throughout his entire dental career. It was only a matter of time before he opened his own dental implant practices in Southern California. 4M Dental Implant Center was opened in Newport Beach, with 4M Dental Implant Center Long Beach opening soon after. Both practices handle all specs of dentistry with a focus on the life-changing 4M Dental Implant Solution. He has a BS in chemistry from UCLA, a DDS from USC, Progressive Orthodontics, Continued Education, Las Vegas Institute for Advanced Dental Studies, the California Implant Studies, Loma Linda Implant Specialty. So you got into USC. So my first question is, how much did your mom and dad have to pay to get your picture on the soccer team to get accepted into USC?
That's a good question.
Does that bother you, Rob? I actually feel sorry for the kids when I hear that their mom paid $500,000 to get in USC. I don't even care about anything other than, man, I feel sorry for that kid. Could you imagine being a child who had a helicopter parent so bad that she paid $500,000 to get you into her college? So first of all, thank you so much for coming on the show. When I look across the dental industry, sure, people say there's 211,000 dentists in the United States. It did 108 billion last year, but the United States is only 4.5% of the 8 billion humans. When you look at the almost 7.7 billion humans, there's 2 million dentists. Dentistry is a very mature industry that's only growing 1 or 2, maybe 3% a year, except for two areas. The only two areas growing in double digit: clear aligners and implant dentistry. And these are the hotbeds of dentistry. And a big reason, when we were taping shows from Tokyo and Paris and London, they were saying, well, the government sets your fee on molar endo. And they only set the fee at Tokyo at $100 a molar. So nobody does molar endo because you go bankrupt doing it. So a lot of things that they love about implants and clear aligners is insurance companies and governments aren't setting the fee.
Right.
They can set their own fee. So you're crushing it in the implant market. Where do you think dental implants is at, and where is it going?
Howard, I think, first of all, thank you for having me. I appreciate it. It's an honor to be here. But implant dentistry, we're just scratching the surface. There is such a vast majority of population that is in need of dental care. And when I say dental care, I mean implant dentistry, not filling and crowns, that we haven't even gotten to, because these patients either don't know about their options. Number two, they can't possibly afford going to the dentist a million different appointments for root canals, for crowns, for every tooth. And number three, and most importantly, they're just scared of going to the dentist. They want to go in there. They want a quick solution that looks good, feels good, and it's economically affordable to them. So that's why implant dentistry is so big today, and it's going to get bigger.
So what is the difference? I see two websites for you: 4M Institute and 4M Dental Implants. Which is one of them B2C for patients and one's B2B for dentists?
Correct. So the Dental Implant Center, 4M Dental Implant Center, is for patients. The 4M Institute is for other doctors or dentists that will participate in learning this procedure of all-on-4 that we teach.
So what would you about a fourth of our viewers are still in dental kindergarten school, and the rest of them are pretty much 30 and under. And I want you to put your dad hat on, because when they come out of school, half of them have already decided, I don't want to do doctor bloody stuff. I want to do bleaching, bonding, veneers. I want to do Invisalign. I don't know. They're afraid of blood. And even if they do a root canal, they're like a pulp lover that wants to stay a 0.5 millimeter from the apex. Then there's guys like me who are an apical barbarian, want to puff a sealer out the apex, and would rather pull a wisdom tooth than do an MOD composite any day of the week. Are these people that want to be fluffy, composite, bleaching, bonding, veneer dentists? Have you seen any of them migrate over to blood and guts dentistry?
Well, let me give you my own personal experience. When I got out of dental school, I wanted to be that cosmetic dentist that does the most beautiful crowns and fillings. I hated blood. In fact, the first time I actually saw blood, I fainted. I really did. So it's because that's what we learn in dental school. That's what the focus of dental school is all about: how to have perfect margins and how to save every single tooth that we possibly can. But once I went through all that, I went through my cosmetics and orthodontics and all the good stuff. There was something missing. And that's when I got into surgery, and I realized how simple it is and how gratifying it is to replace a tooth in 15 minutes. It doesn't have to be that bloody. With today's technology, we can do guided surgery. You don't even see the side of the blood. You don't even need to cut gums anymore, Obviously, if you do bigger cases, full arch cases, then you will get into some bloody stuff. But to start off with, I recommend getting to implant dentistry. All these dentists complain about there's so much competition out there. Every dentist is doing whitening. Every other dentist is doing, Invisalign or aligners or whatever it is. Every dentist calls themselves a cosmetic dentist. So if you really want to be different, then you got to do something different. You can't just sit there and do the same thing and complain about it.
So when I look at your website, 4M Institute, that's your B2B dentist to dentist website, whereas your 4M Dental Implants is your B2C dentist to patient deal. But when the dentist goes to the 4M Institute website, what does the 4M mean? I'm thinking your last name's got to be one of them. Is
right? The 4M
Mohtashami one of them?
Correct. So the 4M doesn't have a particular name, but it would stand for we focus on all-on-4. So the 4 stands for that. And I've done some redesigning in the whole process of the all-on-4, especially in the restorative part. So we've kind of created our own name of 4M procedure or 4M prosthetics.
I think all-on-4, it scares a lot of the kids because they think that's like the most advanced surgery, and they don't want to start all-on-4. They want to start on one tooth. How do you start on one tooth? I mean, yes, okay, so someone's going to get to the top of the mountain and do an all-on-4 one day, but the journey of 1,000 miles starts with a single step. Where is the 4M Institute in that journey? Is it step 1, place 1 implant, 1 missing tooth?
No. So 4M is this boutique institute that's going to teach other dentists how to do advanced implant dentistry. So yes, we do actually offer a couple of courses for single implant for the basically baby steps. But our focus is not that. Our focus is how to teach experienced dentists, whether it's a few years out of dental school or 10 years out of dental school, to teach those experienced dentists to how to take their practices from this level to a higher level by introducing the all-on-4 into their practices. And so we don't just teach them how to do the procedure. We also teach them how to coach their team, how to market, how to restore. So there's a whole package of things that they'll learn.
Wow. And so we had back in the day, we had a gentleman on, Palo Malo, who is the inventor of All-on-4. How long is that procedure out, and do you like it? And has it really changed since Palo Malo started that procedure?
So the procedure initially came out in early 2000, but it wasn't until 2006, I believe, that it actually hit the market. And since 2012, it's become a bigger hit. It's changed my life, and it changes every patient's life on a daily basis. I mean, I change patients' life on a daily basis. Your question was, how has it changed since it came out? I don't think the actual procedure, the surgical procedure part of it, hasn't really changed much. It's just the instrumentation, the product has obviously improved. Now, in some cases, we can do 100% guided surgery with those as well. And I think the most important part is the prosthetic that has improved. You know, back then it used to be just a bar and a denture teeth, where patients will, have denture teeth pretty much, but fixed. But now it's way more than that. We've got so many different options. I think the biggest improvement is in the prosthetic part of it, not so much in the surgical part of it.
And is your institute implant agnostic, or do you prefer working with one type of implant?
Well, we partner with different implant companies. So depending on which implant company is partnered with us, that's the one we use at that moment. But we're open to, as long as the implant has been producing well and they're well known, we're willing to work with them, the implant company. I mean.
And what about software? A lot of high tech CBCT. Is there any same question for CBCT? Are you agnostic, or is there one you like more than others? Or what about the surgical software?
Actually, because being an institute, we are exposed to a few different ones. I don't want to name a particular one at this point, as we're going through some changes with a few different softwares, but there are a lot of good ones out there, honestly. We use a couple of different ones, one from Noble Bike here, but there's definitely more than one software out there that you can use, and they all work well. Let's put it that way.
And that's really a game changer. I mean, when I got out of dental school in '87, we thought we were so lucky because they were installing computers for the class, behind us. And we were high-fiving like we got out of there before we had to deal with any of this computer baloney. And little did we know that computers would completely change the world back then. But do you think that surgical guides, CBCTs, have made placing the implant a lot easier and requiring less surgical skills than, say, back in 2000?
Oh, absolutely. Absolutely. You know what it's like? It's like I would compare it to today's cars with all the cameras. 20 years ago, you only had one way to park your car, right? You had to look over your shoulder, and you had to look around and figure out how you're going to do your parallel park. But today, you can either do that, or you can use all your camera in the car, and that camera will help you 10 times more to be able to park your car. So it's the same thing. My recommendation would be to learn how to do everything surgically, because just in case you get to a point where you can't use your surgical guide, which it happens once in a while, then you know how to proceed and do the surgery the way it's supposed to be. But surgical guide has come a long ways, and most of especially with single or double implant surgeries, we can just do it guided, no problem.
What would you say to the 1,000 prosthodontists who never know if they should start placing implants or not because It's called channel conflict. They're afraid if they learn how to place an implant that maybe their referrals are going to stop sending to them. What advice would you give to prosthodontists? Should they learn or not?
100%. I mean, I believe that every prosthodontist should learn how to do the surgery. Every oral surgeon should know how to restore implants, only because it helps you to see the final product, or vice versa. If you're a prosthodontist, if you know how the surgery works, you can communicate. Even if you decide not to do the surgery, you can see things so much more clear. One of the advantages that I think I have is I can do both. I've done all the prosthetics. Now I do all the surgeries. I can just put the two together. I used to refer to oral surgeons, and the cases would come back. Not that the implants were done wrong, but the angulation and certain prosthetic parts were not being looked for or taken into consideration, and that would make my job a little more difficult. And same thing goes for a prosthodontist. If they know how to do the surgery, they can communicate better. They can treat the patient just all around way better.
And what is on Dental Town? I just want to get this out of the way. I don't know if you're going to laugh at this question or take me serious, but under implantology, it's one of the forums. It's one of the most visited volume forums. It's all over. But we had to separate implantology from mini implants because they just my gosh, anytime they don't respect each other. And I don't like that. I mean, I think we should all get along somehow. But what is your view on mini implants? Is there any place in dentistry for mini implants or no?
I mean, there's definitely a place for it, but it shouldn't be a big place for mini implants. If you have a really, really tiny space, limited bone, I see the mini implant being overused a little bit. I've seen cases where you could place maybe, an edentulous arch. You can place 2 real implants versus they've used 5 or 6 mini implants. And I kind of relate it to, if you're going to put a big TV up on the wall, do you want 10 nails on there or do you want 2 big screws? Which one works better? So there is definitely some cases for mini implants, but I think sometimes it's being overused for no reason, where we can use actual implants that works way better.
And is Dr. Ben Javid, is that prosthodontist, he's a lead educator at Farran Institute? Is he your partner in all this?
Yes, he is.
So so talk about him for a second.
He's a prosthodontist. He's been doing all on 4. He does also the surgery. So here's a prosthodontist that does the surgery and the prosthetic part. We met a couple years ago. We both have the same vision. We both really practice very similar, which was great. And that's when we started the Farran Institute in Long Beach, so we can teach other dentists how to change lives just like the way we do. He's very book smart, and I'm a little bit more clinical smart. So the two of us together actually really fit well together. And when we teach the courses, the comments we get is that you guys really put a good show together. I mean, it's really nice to work with him. So,
when, I've been, I think I graduated from dental school in 87. A lot of, back then it was really bizarre because the early implantologists were really, not respected in 87. I remember at UMKC Dental School, the one oral surgeon who placed implants was always called the butcher. I know when I came out, the early implantologists were doing all these great subperiapicals, subperiosteals, Ramus frames. They would take dental cripples and rehabilitate them. But the first time they had a major case fail, the boards would take their license away. And it was so cruel to watch some of these really successful implantologists and end up lose everything they have and go drink in a trailer until they died. I mean, I saw this. And now when it's mainstream, I always want to, whenever someone's arguing with someone, I always say, settle down. The jury's still out. But back in the day, the implant used to be, the goal of the implant was to have the longest implant possible. I mean, you wanted it to go all the way out of the head, around the moon 3 times and back down. Now you see shorter, fatter implants. And, I think everything should be shorter and fatter, but that's just me personally. Are you seeing a lot less sinus lifts now that shorter and fatter implants is more common, or is your procedure all on 4? Isn't that the main reason people like all on 4? Because there is no sinus lifts or anything? Explain what an all on 4 is and why there would never be a sinus lift for these shorter, fatter implants.
All right. So all on 4 is when we place 4 implants in an edentulous arch to support a complete prosthesis. These 4 implants, the front 2 implants are placed pretty straightforward and pretty straight up and down, but the back 2 implants are tilted posteriorly or distally to where we can skip the sinus, but yet we use very long implants. Actually, they're not short implants. They're long implants to where we can maximize the amount of the bone that's there. The anterior part of the implant is more anterior to the jaw, where that's where the strongest part of the bone is. As you know, as we go further back into the jaw, the bone gets softer, especially on upper arch. So what we do is we tilt those implants so we can get the anchor of the better bone more anteriorly, and yet the posterior part of the implant will be further back distally. So this gives us a nice AP spread, anterior-posterior spread, for a nice prosthetics to be restored.
And does the patient, I mean, you're out there in high aesthetic needs. I mean, you're out there in Southern California. I mean, that's that would have to be the highest patient expectation for beauty. Obviously, every hygienist is going to want that to be a all-on-4, to be a removable, so you can take it to the kitchen sink and clean it and brush it and snap it back in. But I know patients psychologically, when they're paying all that money, they want it fixed. So how do you judge the easy to clean with having it snap out, and versus that psychological? It's like me, I won't wear a wig because I'm so afraid it will blow off when I'm walking, that I just go without it. So how do you balance that, the hygiene needs versus the psychological needs?
The hygiene need of the all-on-4 is actually very simple. Obviously, the outer surface of the teeth you just brush normal, like you would. But if you can imagine what a pontic on a bridge looks like, imagine that across the whole arch. So the amount of contact between the prosthesis and your tissue is almost like a pontic on a bridge. It's not huge, it's pretty minimal. And with using what we call a hydroflosser or some kind of an advanced water pick, they can easily clean under it once a day, and that's all they need. Out of the thousands of cases, arches I've done, honestly, I've had a single patient complain that they're afraid they can't clean it. No one else has ever complained. And that one patient was wearing dentures for probably 40 years, and the fact that he couldn't remove it kind of bothered him. But nobody else ever complains.
So if you do 100 units of all-on-4, how many of them are fixed versus removable?
All right, so when you say all-on-4, you are talking about a fixed prosthesis. We're not talking about removable.
You can't make any removable
off
an all-on-4?
You don't call that all-on-4. You call that overdenture or snap-on denture, or there are other names for them, removable, supported denture. But when we're talking about the term all-on-4, the procedure all-on-4 is a fixed prosthesis that's all done in one day. Patient walks in with no teeth or with teeth that need to be removed. Same day, leaves with fixed prosthesis. So that's what you call all in four.
So that includes all done in one day.
Correct. So we also call it teeth in a day or all done in one day. Yeah, some people call it all done in one day.
So so then you compete with Clear Choice.
Exactly.
And how does that go? What is your unique selling proposition to go against Clear Choice?
I mean, Clear Choice has done a great job to market this procedure for all of us. So we can't take any credit away from them. They've done a fantastic job. They've helped all dentists around. But what sets us apart is not so much in the surgical part of it, but in the final prosthetic part of it. Like I said earlier, the material used, there are different things that can be used to give patient that beautiful smile. You could go from denture teeth to all zirconian teeth, or there are all these different things in between. I think our product is superior to what All-in-4 uses. And I can get into more detail on that if you wanted me to. But
sure. Is it the teeth? Is it because I always think Southern Cal, for some reason, whenever I'm talking to a dentist in Southern Cal, I always think it's a higher aesthetic need. I mean, Bob Ibsen started Denmat in Santa Maria because, it was just beauty was first. I mean, he wrote the first book on adhesive dentistry because no one wanted to hear how long amalgams last. They wanted it tooth colored. And then when he started making Denmat composite fillings, he was shocked that the patients noticed that Crest and Colgate dulled the luster, and they dulled it because the toothpaste wasn't abrasive enough. So he made it with a titanium dioxide and came out with Rembrandt. So I assume that your advantage on Clear Choice is something to do with the aesthetics of the teeth.
So there are two major products. Yeah, you're absolutely right.
Was I close?
There are two major products that are being used for the final teeth. One is titanium bar with denture teeth, which most of the time is what Clear Choice uses. And the second option is full zirconium bridges. Now, each have advantages and disadvantages. The titanium bar with denture teeth, it's light. It's not strong enough, so a lot of these teeth keep popping up or breaking off after a year or two, and there's a lot of fixing that needs to be done, or repairs, I mean. So that's one option. The other option is the full zirconium. The full zirconia, the advantage is that it doesn't break that easy. So you have this really heavy piece of bridge that's screwed into 4 implants. Now, there's a lot of wear and tear that happens on when you have such heavy piece of zirconia. And patients, when they talk and they chew, you get that chopped down or that loud noise when they chew. So overall, the disadvantages of the zirconia is that it's too heavy and it wears down the implants too quick. We brought these two together. We took the advantages of the lightness or the flexibility of a denture teeth and the strength and the aesthetic of the zirconian teeth, and we combined the two together. So we use the material called Zirpeek, Zirpeek, Zirpeek. This material has the strength of the zirconia, like I said, but it's still very light. So the patient doesn't feel like they have something heavy in their mouth. And on top of that, we do individual crowns. It's just like you having 16 crowns in your mouth. So if for whatever reason, if one breaks, we can just replace that one crown as if literally if it was a crown prep. And it's just as easy as that. So those are the advantages of what we have. And aesthetically, it's just amazing. Each tooth, you can almost floss between each one. It's beautiful. You got to see it.
And why do you think Clear Choice Holdings is up for sale? Why would you guess?
Well, Clear Choice is, I believe, that's their model. Their model is to build and then to sell it to a private equity. I think that's their model. That's what they do. They've sold it 3 times already.
Yeah, it's on the block again. They're saying that the projected EBITDA offer is north of $50 million. It's a weird game because none of them want to go public. I mean, you're out there in California. Why can Snapchat go public when, I could live another 57 years without even knowing what Snapchat is? I still don't know what it is. But how come these big healthcare providing companies, why aren't they published? Why aren't they publicly traded on NASDAQ?
I'm a great implant dentist, but I'm not good at this. Correct me if I'm wrong. I don't think you can go public with service companies. When you're giving patients or whoever a service, I doubt it if you can go public on that. Am I right or wrong?
You can go public if you get the revenue. I mean, if you're...
It could be that, that's a good question.
But it is wild. Like Kevin Mosier started the company in 2005, and like you say, it's been flipped 3 times. It's just a weird game that you have these major dental players, and their only goal is to sell it to a private equity, whose only goal is to sell it to someone else. It's kind of like, what was that game on the chairs where you'd go around the chairs, and then when the music stopped, everybody had to find a chair. That is just is there an aesthetic health compromise in doing this all in one day? I mean, if you were doing this for your own mom or your own dad, would you say, you know what, the burden of doing this all in a day, and I mean, yes, there's a huge market for that. I mean, that's the American way. I mean, I couldn't think of another country to start this in than in America. I mean, teeth in a day. But do you think it would be better if it was spread out over more days or weeks or months?
Not this particular procedure. I mean, if you want to spread it out, so let me back up for a second. This procedure is designed for patients that want quick results, patients that don't have a lot of bone, patients that don't want to go through sinus lift and 6 months of healing, patients that don't want to spend $70,000 or more in their mouth. I mean, there's definitely a reason why this was designed. Yes, you could. There are definitely patients out there, and there's definitely candidates that would benefit from 6 to 8 implants, sinus lift, waiting 6 months, wearing a denture for 4 to 6 months initially. But that's going to rule out about 2/3 of the population. So what we're doing, we're serving that 2/3 of the population that doesn't want to do all that doesn't want to go to dentist 100 million times. They want teeth today. They don't want to wear removable for 6 months. A lot of patients are hanging on to their infected teeth, to their gum disease teeth, because they're afraid of what's going to happen once they take their teeth out. As soon as you tell them nothing is going to happen, the only thing that's going to be great is you're going to walk out of here with healthy, fixed teeth that same day. And that's what they're looking for. When they hear that, they get excited. So would I do that same thing for my family? Absolutely. After doing this procedure for so many years and seeing the benefits for every single patient, I would do it for my family 100%.
So implant forms is big on dentistry. It's one of the most busy ones. And a guy posts on an implantology, all on floor with clicking joints. He's currently working up a case with the periodontist that everybody wants to do an all on 4, and they says she has noticeable clicking of her joints bilaterally, but is currently asymptomatic. What goes through your amazing mind when you hear that?
The first thing that goes through my mind is, why does it have to do with the all-on-4? How do we know it's from the procedure of all-on-4? Why?
No, he hasn't done the all-on-4. He's working it up. The teeth are trashed. The patient wants the all-on-4, but she has clicking. She has noticeable clicking of her joints bilaterally, but it's asymptomatic.
I've treated many patients, even with TMD disorder or TMJ disorder, who've had pain, discomfort, and we were able actually to treat them and resolve their issues. Maybe not 100%, but 70%. I can think of a couple of patients actually right now as we speak. So what would you do if we were to restore this patient without any kind of implants or without the all-on-4? We would still want to correct the patient's bite, place their bite in the right position to where their TMJ is comfortable. Whatever system we're going to use, we're not going to get into that, whether it's neuromuscular or whatever it is. But we would do that with placing the patient in a splint, in a orthotic, monitor for 3 to 6 months, adjust their bite until they're comfortable. Then we would either orthodontically move their teeth or crown and bridge their teeth to place them in that position, right? That would be the restorative way. Now we can do that same exact thing with all-on-4, so that shouldn't stop us. If someone has the talent, the knowledge to treat a patient for their TMD, it doesn't matter whether they're doing it from the all-on-4 perspective or 100% crown and bridge or orthodontist. It should all be the same. The final results should be the same.
One of the problems that people worry about all-on-4 is, the person that needs an all-on-4, that's not going to be your vegan yoga instructor who eats kale 3 times a day. I mean, that's most likely going to be your drinking, smoking Irish guy who, so a lot of people say, what I'm worried about all-on-4 is the reason they needed all-on-4 is they didn't have home care to begin with. And now they've had all this all-on-4. I know that my hygienist, they when the patients come in with all-on-4, they want to have the whole thing removed, clean, and put back on. But that's an extensive cleaning appointment. And ClearChoice doesn't really want to do. They don't have a hygiene department for those, do they?
I'm not sure about ClearChoice, but we do.
Yeah, because that's one of the major complaints about ClearChoice is they do all the teeth in a day, but they really don't. Then they want you to go back to a regular dentist. But so specifically the question, if you're a hygienist, they come in, do you always remove the prosthesis at the 6-month cleaning? Is it on 6-month recall? Are they 4-month recall? How does that work?
So our protocol is after we deliver the final prosthesis, we want the patient back in 6 months so we can evaluate and see how their hygiene is. If they're doing a pretty good job and things are good, then we put them on a 1-year recall. So once a year, they come into our hygiene department, we remove the prosthesis, we clean, make sure all the screws are nice and tight, nothing is moved, nothing is basically loose, and then they go on their way. And it's a very simple procedure. It's way easier to unscrew 4 little screws and clean a prosthesis and put it back on than cleaning 16 teeth in an arch. And you have, even not only for us, it's easier for the hygienist, but also for a patient. So imagine a patient that has gum disease or has hygiene issues. In one arch, you have, let's say, 14 teeth that have circumferential pockets that this patient needs to worry about, right? Brushing, flossing, if they have 5 or 6 millimeter pockets, that's a lot of pockets for plaque to sit in there and cause more gum disease and more issues. Now you take 14 teeth away, you put 4 implants, and these implants are obviously a lot smaller than a molar. Now all of a sudden you cut their work in 1/16 or 1/12, I'm sorry, whatever the math comes out to, right? So their hygiene maintenance is a lot easier. I see patients that have had all their teeth removed because of advanced perio disease, and 2-3 years later they come to me and they're healthy still because it's so much easier for them to keep the all-on-4 clean than their natural teeth.
And what I really like is, like, say, back in the day, nobody liked to water pick because it made a mess in the bathroom. There was water on the mirror. It was crazy. But now they make these water picks that you can take into the shower.
shower. That's right.
And so when you water pick in the shower, it's just a lot more easier to do. They start out with the shower floss. Remember the shower floss where you would take off the head of the shower and you'd screw that on there. That was great. So that's a very interesting protocol. What about peri-implantitis though? Again, this is most people who lose all their teeth enjoy smoking, drinking, and Smirnoff. Do you have what is your failure rate of these implants from peri-implantitis and et cetera?
So peri-implantitis doesn't cause failure. It may cause some issue, it may cause some bone loss and so on, but it doesn't cause failure. The only thing that really causes implant failure is in the first 3 to 6 months. If it doesn't heal properly, or if we get movement of the implant or too much pressure. But our failure rate, let me tell you about our success rate is at 97%. And we kind of keep track of that as we go all the time. We have a really, really high success rate. When implants are placed and they're splint together, and we never have to unscrew and screw back an abutment or a healing cap, that tissue heals really nice around those abutments. So at the time of the surgery, we place the implant, we put a final abutment, which is called multi-unit abutment, and we never remove it. It's done. So that first primary healing that you get around that implant and around that abutment is never bothered again. And that's really a big success versus single implants where you place the implant. 4 months later, you remove a healing cap, and then you put another impression coating, and then 2 weeks later, you remove that, and then you put another abutment. And so every time you do that, you're interrupting that periodontal healing or the periodontal pocket or tissue. So that's another success of the all-on-4.
So you're saying that if implants are going to fail, they're going to fail right out of the gate in the first 3 months?
First 3 months, we would know, yes. Very seldom 6 months, a year later, but most of the times in the first 3 months, yeah.
But when you count your 97% success rate, are you counting including the failures in the first 3 months, or do you mean after that first 3 months? It's the one.
All of them, even the first 3 months.
Because that's one of the confusing things about life expectancy of humans. It was always the infant mortality rate, and a lot of people believe that 10,000, 15,000 years ago, people didn't live very long because they were talking about a median age with that infant mortality. But when you cleaned out the infant mortality, they actually lived a very long time. Right. But you're saying you have a 97% success rate, including the high initial the failures are in the first 3 months.
Correct. It's included.
And the other thing is, who is that failure in the first 3 months? Because they come out of dental school and they're told, well, a good candidate wouldn't, smoke, drink, cuss, or be Irish. And then they open up their practice, and those are the people that need it all. So again, what do you think sums up that 3% failure rate out of the gate?
I think most of those 3%. Including the ones that actually don't follow instructions and they go home and do everything that you told them not to do, but they still do it. Mostly are autoimmune deficiency patients, could be diabetic patients, type 1 or type 2. Smokers are definitely in that category. I think those are the two most important failure factors, is smoking and diabetic.
Yeah, I know Carl Misch, when he was on the program, and he said he did smokers. I know that was one of the more controversial things he said. The other controversy, there's a lot of implantologists that just say, I will not do this on a smoker, end of story. There's other people that say, everybody needs a dentist and everybody needs a chance. How do you draw the line between being a tough guy and saying, no, I won't do it if you smoke, versus I know you're a human. Humans are complicated. As long as you're aware that, So how do you balance crazy people versus high tech medicine?
I think I agree with what you said earlier. Everybody deserves a chance, and I've learned that if I explain to my patient in advance what their risks are for them if they're smoking. And if they agree to go ahead and move forward with the procedure, who am I to not do it for them? Because not every patient that smokes is going to have an implant fail. Yes, there will be some, but not every single one of them. So as long as the patient is informed, and that's what we do, as soon as I find out someone is a smoker, I would recommend for them to stop smoking if they want the implants to last a lifetime. And if they say, I will not stop smoking, then my next question is, would you still want to proceed knowing that there's a chance that your implants will fail? And it's 100% a patient's decision to move forward or not. It will not be my decision at that point.
What if they just switch from Marlboro to Marlboro Light? And Bud Light to Bud Light. It
might help.
So is there there's other people that are afraid to scale. I'm on Dental Town, and there's a big long thread about all on four. What do you do? One dentist says, well, I'm afraid to remove it because I'm afraid if I remove it and don't get it back on, I now own it. The other person says, do not scale the implant because that's bad. Do you think for a while there, a lot of people were making cleaning instruments that were plastic so it wouldn't scratch an implant? Is that something that you think about or not really?
Yeah, I mean, our hygienists use plastic instruments, and we also have ultrasonics that are specifically made for implants, for implant cleaning.
Mm-hmm. And then another guy asked on implants. He says Medicare and all-on-4. Has anyone ever successfully been paid by Medicare for any part or all of the all-on-4 procedure?
I wouldn't know because I don't work with Medicare, so I honestly could not answer that. I know that they would pay for the extractions and maybe for the denture part, but definitely not for implants. But I've never tried it.
So have you ever tried medical billing for it? Not Medicare, but just medical billing?
We've done some medical billing, but that's through normal insurances, not Medicaid.
Yeah. Have you been successful with that or not really?
We've only done occasional cases where we actually knew that we had a pre-authorization. So we don't just, patients don't just walk in here and say, oh, I have a medical insurance. Can you just bill my insurance? And then we do the procedure and bill the insurance. We can't do it that way. But there's been a few cases where patient came to us and specifically let us know that their insurance will cover. Then we send them pre-authorization. We got the pre-authorization. Then we went ahead and did the procedure.
Another question. Somebody posted an article, The All-on-4 Treatment Concept, a Systemic Review by Sebastian. It was a nice study, but basically the question is, the patient's always going to ask, how long will this last? How do you set expectations for a complicated human? I mean, if you buy a car, a refrigerator, the consumer's got to have some framework in their mind about what would be expected or not expected. How long do you think? How do you guide? They say satisfaction equals perception minus expectations. How do you form expectations of longevity with this procedure?
I tell my patients that nothing in life ever lasts forever. I mean, even God gave you teeth that don't last you forever, right? So I'm not better than God. So I'm not going to promise you teeth that are going to last you a lifetime. But what I will promise you is I will place implants that are successful, 100% successful. And if you maintain and come into our office for your normal, regular hygiene, I will guarantee those implants, meaning that if 7 years down the line, if one of them fails and you've been coming in for your yearly or 6-month checkup, then I will replace that for you at no charge. That's the way I do it. But I do not guarantee the prosthesis because I don't know what they're going to do. I tell them that the prosthesis or the teeth that you wear over those implants are kind of like the tires on your car. It depends on how you drive them. Depends on how many miles you put on it. It could last you a couple of years. It could last you 6 months or 10 years. I really don't know, but that's how we go about doing it. And patients are very susceptible to that. They understand.
And what kind of labs? I mean, Glidewell does labs now for all on four. There's a guy posting a picture today of a prosthetic that he got back from Glidewell Labs. Did you know Glidewell was doing these procedures?
I'm not sure if they do the actual surgical part of it, but I know they do restore them. Yes, I know.
I mean, yeah, the lab for the restorations.
Yeah.
So,
Yes, I know.
So do you have your own lab, or do you use Glidewell, or do you have?
We have our own laboratory in the Farran Dental Implant Center in Long Beach. So all of our cases comes here to Long Beach in-house lab. Yes. So we don't use any outside labs. And that's where I was telling you about the advantages that we have over Clear Choice is in the prosthesis, in the teeth that we actually create, the Zerpeak that I told you earlier.
Wow. So, that's, a lot of people say that was Aspen is why they were the most successful DSO, is instead of doing mergers and acquisitions and buying other people, they had their own model, and that model was included a lab.
Mm-hmm.
And I see that business model. I mean, when I grew up, my next door neighbor, Kenny Anderson's a dentist. That's why I'm a dentist. I wanted to be him when I grew up. And he had his own Crown and Bridge lab. And it seemed like it was really common back then. I mean, on the west side of Wichita, it seemed like every third or fourth dentist had their own Crown and Bridge man. Of course, it was simple, a one-man operation, a PFM or a Gold Crown. Do you think putting a lab back in the dental office like Aspen is doing now is something that we're going to see more of? Is it a big strategic advantage? Do patients like it? Do you think that's a big part of your mojo and success?
Definitely. I mean, especially if you're doing the all-on-4 cases, and that's where your practice is headed, you definitely need to have your own lab. I mean, it's very critical to be able to duplicate things in a timely manner, or provide patients with services that are required in an all-on-4 practice. And you cannot do that if you have an outside lab. For example, Glidewell, every time you send something, it takes 2 to 3 weeks or whatever the procedure is for it to return back to you. I mean, you can't really sustain unless you're doing 1, 2, 3 cases a month, maybe. But if you're doing that on a daily basis, you definitely need to have an in-house lab at some point.
And Lila asked on the all-on-4 thread, how do you close up the all-on-4 screw access holes? From what I've learned, Teflon tape to fill the holes and a couple millimeters of composite without any adhesive. Is that how you do it?
Yeah, very simple. Exactly what you said. Sometimes if we know that the patient is coming back in 6 months, we put the Teflon and we backfill it with some light body impression material. So that way, when the patient comes back, the doctor doesn't need to go back in there and drill it out. Because with composite, now you need a doctor to go in there and drill that composite out. But if you backfill it with light body impression material, you put an Explorer in there, you pull it out, the whole thing comes right out.
And I know I can't believe we already hit an hour, but who are these people getting it all on for? I imagine a lot of people. It's real easy to say, well, Sean's out there in LA and he's getting a bunch of movie star millionaires, and I'm in Parsons, Kansas, and we don't have all the movie stars and millionaires. Or is it mostly rich people, millionaires and movie stars, or are they Walmart people?
They're Walmart people. Most of our patients are blue-collar patients. These are patients that haven't had the proper, whether it was finances or time or whatever it was, they didn't have the proper dental care. And now they're at a point where their life has hit a place where they just can't go further, whether it's in their love life, whether it's in their occupation, or whatever it is. They've kind of hit a spot where they just need something new. They need help. A lot of our patients get help from family. Mom and dad or cousins come together, they co-sign for them. we really rarely work on millionaires. I mean, we maybe once in a blue moon we get someone that walks in here and writes a check for us, but most of our patients, I would say 90% of our patients, are done by financing. And these people are not rich.
90%?
Yeah.
And who is the financing? Is it Care Credit? Is it
Through third parties? We do Care Credit. One of the big ones we use is Green Sky. Definitely want to look into that, because Green Sky is probably the only finance company that does $50,000, $40,000, some big numbers. I think all the other ones have a cap of 20 or 25. So for these big procedures where you're doing a full mouth, you need Green Sky. There's Springstone. There's Wells Fargo. There's quite a few of them.
And what is your fee on average for something like this?
We charge around $25,000 per arch.
$25,000 an arch?
Per arch, yeah.
And what are and what's Clear Choice charging for that?
About the same. I know sometimes in the beginning of the month they go up to 28,000, and then towards the end of the month they come down to 22, 23, depending on, how desperate they might get. But we're also flexible. We're really here to help patients. So if some patients' financing comes to a certain point where they need a few $1,000s of help, we help them. We really do. We're here to change patients' lives, and we don't let a few $1,000s get in the way. So that's what we like to charge, about $25,000 per arch. Sometimes if we're doing a full mouth, we may be a little more flexible as well, upper lower. But I want to add back to where you said some of the doctors say, well, I don't, live in Beverly Hills and I don't have these patients, millionaire patients. There's a huge market out there, and these people are the blue collar market that really, really need this procedure. I'm going to give you an example. We have a little bit of time, don't we?
Yeah, I'll go all day.
If you look at Southwest Airlines and find out how Southwest became Southwest, it wasn't because they came into the market to compete with Delta or American Airlines or all those other good airlines that are out there. They came out to the market because they knew there are a lot of people that hate to fly. They rather drive to Las Vegas for many reasons. Number one, it's too complicated to buy a ticket. You got to call, in case you don't want to fly. Your money is never returned to you. You lose your ticket. It takes too long to go through the airports. So there's all these complications that made people not want to fly. So Southwest idea was, what should we do to grab those people that don't want to fly and bring them into the market of flying? And that's how they basically created the philosophy of, when you call the first ring, somebody answers, your money's always there. If you don't fly, you can reuse it towards other flights. Simple get in, get out. There's just so many things they created. So now take that into the dental world. There's so many patients out there that don't go to the dentist because they don't want 100 appointments. They don't want a root canal every tooth. They don't want to go in for 20 cleaning appointments and then have to do it every month. They don't want to spend $70,000. They cannot afford it. There's just so many, or they're scared of going to the dentist. When you put all this together, this all-on-4 fits into a huge market that's just sitting out there that nobody's tapped into. So if you're a dentist that feels like there's too much competition in the dental world, there's absolutely zero competition in the all-on-4 world out there. There's just so many patients just waited to be treated.
Well, I'm always beating them up, telling them over and over and over that the average American buys 13 new cars in their lifetime before the age of 76. That's a verified, obvious number. My gosh, it's from the average new car price in America is 33,560. Source Kelly Blue Book and USA Today. On average, Americans buy 13 new cars by age 76. Source Anthony Pratt, Polk, Director of Forecasting. So you're selling a dental cripple, a dental solution for $50,000 to an American who will buy 13 new cars in their lifetime, and 95% of dentists will never sell one case their whole life worth $33,560. So what separates the big boys like you with wearing big boy pants versus 95% of Americans who say, well, my patients don't have any money, even though they're driving a $50,000 Ford 150 pickup truck, which tonight is Monday. It's my favorite night of the week because it's Monday Night Football, and it'll just be all commercials for Ford 150 pickup trucks. And if you're poor, you'll get the F-150 for $50,000. If you want hotter women, you'll get the F-250 for $75,000. And if you want the hottest girl on the block, you'll get the F-350 for $100,000. So what are dentists thinking when they watch Monday Night Football and see all these car commercials? I mean, do they think just people in Beverly Hills drive trucks?
I think one of the problems with dentists is they think for their patients. They choose for their patients. How many times has a patient walked in and a dentist decided, oh, this guy can't afford whatever it is, so I'm going to give him a lower option without really knowing if this patient can or cannot afford it. That's the biggest problem that I see. I stopped doing that a long time ago. I will not choose for my patients. I will tell them their choices, and I will allow them to choose.
And you said that these were blue-collar workers twice, and I have to tell you about blue-collar. The word blue-collar comes from because they would wear blue denim. And in the 32 years that I've had in my dental office, I've had a couple of people who retired here, and they always come in plaid pants or the striped pants. They kind of look like Goofy from like 1950. And you get to know them over the years. And they're so proud that they've never worn blue jeans ever. Because if you grew up during the Depression, it is really, you really made it if you never had to wear blue jeans again. But some of the point I'm trying to make is some of these corny old goofy looking men wearing these plaid pants that they don't even sell anymore. You know, J.C. Penney's wouldn't even carry these things. And you look at him and you think, this guy's a homeless guy. He doesn't have a dime. But he's got $50,000. When he buys an F-150 pickup truck, he writes a check for $50,000. So everybody needs a dentist, and they don't need your judgment. They don't need your, if they want to be judged, they'll go to church.
Right.
If they have a finance problem, they need to go to a bank or Green Sky, not you. You're the dentist. You're supposed to tell them these are your options. Not woulda, shoulda, coulda, you're bad because you smoke and you shouldn't have been born Irish in the first place. You drink in full. You should be a yoga instructor, not a welder. I mean, this has nothing to do. They're here at your door. They have the money. And I just, my gosh, I drive around these streets of Phoenix, and it's amazing how a city of poor people with no money, they sure have a lot of nice cars on the freeway, don't they? But I can't believe how long we went. You're being so nice. You let me go well over an hour. But is there any question that I should have asked that I didn't ask?
If I have to make any suggestion to the dentists, my colleagues out there, is number one, don't judge the patients. And number two, go get trained in being able to do these, because it starts with your confidence. If you're confident that you can provide this service to your patients, it'll come across and people will buy it. And number three is get your team members trained and on board. If you're only the person that knows how to do a procedure and your front staff don't know how to talk about it, your marketing doesn't apply to that, then you're going to get disappointed, because those kind of patients don't come through just out of nowhere. So train yourself, train your staff and team, and start marketing out there. You'll see how it just start flowing in.
And when are they ready to visit you're not the place to go to place the first implant?
Well, we do have a couple of those courses coming up in 2020. So if you want to just learn how to do single implants, yes, you can come to our courses in 2020. Go to foruminstitute.com. But if you're already placing some implants, even if you place 20 to 30 implants, you should be able to now get into the all-on-4. Come and learn how to do this procedure. I mean, I have oral surgeons, periodontists, prosthodontists who will never place the implants or do the surgical part. They still come and learn it every time they walk out of here saying that this was an eye-opening for them.
And what percent of the patients, when they get all-on-4, are put to sleep? And do you teach that, or do you use an anesthesiologist and that's separate training, or?
So both me and Dr. Javed are licensed for IV sedation. So most of our patients are IV sedated by us. If a patient is medically compromised, then we have 2 or 3 days out of the month where we do just anesthesiologist cases. Those are compromised cases. For doctors out there, we don't teach the IV sedation here, but there are a lot of good courses you could take. That doesn't have to be the fact of, or that doesn't have to be the determining factor whether you do these cases or not. When I first started it, I would do oral sedation for patients. Just start with one arch. They're not that complicated. Obviously, if you do a lot of them, it's a lot easier and you save a lot of time if you could either have an anesthesiologist or do the IV yourself.
Well, you're out there in Southern Cal, so I assume that Michael Jackson, you have to use propofol.
I don't use propofol, but I'm sure the anesthesiologists do.
My anesthesiologist, he's so upset that Michael Jackson used that one because he said it really hurt the brand. He gets about 10% pushback on that. My gosh, a great marketing for your course. We put up 400 1-hour courses on Dental Town, and they've been viewed almost 1 million times. Oh, wow. It sure be an honor to get you to do online CE course on all-on-4. So they can get to know the concept, they get to know you, and maybe they're ready for you now, or maybe they're still in dental kindergarten school, and it'll give them something to look forward to someday when they grow up. But if you're ever interested in that, it'd be an honor to have you do an online CE course on Dental Town.
For sure. We'll do that.
All right. Well, thank you so much for staying an hour after a long day of work to talk to my homies. It was just an honor to podcast you today.
It was my pleasure. It was very nice talking to you.